Alright, this is Patrick Salim under PS&2D, and welcome to the video. Now, I'll be laying out a scenario where our patient RK, a 51-year-old with a history of coronary artery disease for 13 months, has been recently admitted to the ER. Now, after in the ER for 15 minutes, the patient is admitted to the coronary care unit for continuous monitoring and treatment. Now, the CCU doctor orders to give Retaplace 10 IU stat plus another 10 IU after 30 minutes and heparin of 5,000 units every 4 hours after giving Retaplace. Now, there's a series of questions that we need to answer. Number one is to differentiate stable angina, unstable angina, and myocardial infarction clinical signs and symptoms, and its pathological changes in the coronary artery and myocardium. Now, angina is caused by a lack of blood supply to the heart muscle, which occurs when the coronary arteries constrict or become blocked due to atherosclerosis, muscle spasms, or a blood clot. Angina commonly occurs as a result of physical exertion or emotional stress, putting the body's demand on the heart to circulate more blood and oxygen, and however, the body, because of the blood, the heart is unable to meet the demands of the body. Angina pectoris, as previously mentioned, is a type of chest pain or discomfort provoked by physical exertion or emotional stress. However, this can be relieved by rest or anti-anginal agents such as nitroglycerin. Now, this is what we call stable angina. The pain can be mild or severe and may produce numbness or weakness in arms, wrists, or hands. The pain usually radiates from the neck, jaw, shoulders, arms, hands, and the posterior infrascapular area or the back of the shoulder. Now, the pain occurs more commonly on the left side than the right side, usually lasting from 2 to 15 minutes after stopping activity or at rest. And usually, nitroglycerin relieves the pain within 1 minute. Now, the associated symptoms with this includes diaphoresis or excessive sweating, nausea, indigestion, dyspnea, tachycardia, and increase in blood pressure. Now, men, especially women, experience atypical symptoms of chest pain, such as jaw pain, shortness of breath, or feeling of indigestion. Angina pectoris also occurs due to exposure to weather extremes, after eating a heavy meal, after sexual intercourse, or sympathetic activity. Now, unstable angina, on the other hand, is a chest pain occurring at rest. No increase in oxygen demand is placed on the heart, but there is an acute lack of blood flow to the heart, which occurs because of the coronary artery spasm or the presence of an enlarged plaque or a hemorrhage or ulceration of a complicated lesion. It can be stable angina first. However, if 10 to 15 minutes have passed, even with rest and medication, it's still not relieved, it means it's an indication of unstable angina. Basically, when there's a change in the frequency, duration, and intensity of stable angina, it's an indication of a progression to unstable angina, or aka the pre-infarction. Now, the myocardial can happen if symptoms of stable angina is not attended or corrected immediately, and their management is the same. Myocardial infarction also has the same pathophysiology with the unstable angina, and pain is usually severe. Now, the only difference is that unstable angina is that there is no damage yet to the myocardium muscle cells, and in the myocardium infarction, necrosis is already happening, meaning there's a damage in the myocardium cells. It is very dangerous and worrisome. Number two, why did the ER doctor prescribe morphine, and how will morphine help our patient? Morphine is a narcotic analgesic, a drug of choice to relieve pain. It can help our patient because morphine acts in reducing heart rate, blood pressure, and venous return, while also possibly stimulating local histamine-mediated activities. In theory, morphine lowers myocardial oxygen demand. Number three, why did the doctor prescribe Retaplace, and how will Retaplace help our patient? Now, our patient is diagnosed with acute coronary syndrome, indicating that the coronary artery has been completely blocked. Retaplace will help clear by dissolving the clot or blockage of the heart muscle to prevent infarction. Now, why did the doctor prescribe heparin? How will heparin help our patient? As previously mentioned, there has been a complete blockage or clotting of the myocardium. Now, this heparin will help prevent further clotting. Number five, what are your nursing priorities for patient and in coronary care unit during and after administration of Retaplace heparin? Now, remember, time is important here. Once prescribed, administer drug as soon as possible. So when administering Retaplace, we need to always be careful in giving the correct dosage and should be the one like as prescribed. Overdose do not have specific treatment, but to stop medication immediately once signs of bleeding is noted. And for heparin, keep antidote, the protamine sulfite on standby in case of accidental overdose. Do not give drugs simultaneously through the same IV line, and they must be in the separate. Because Retaplace and heparin is not compatible with each other, so they must never be combined in the same solution, and because it can increase the risk for bleeding, and we don't want that to our patient. Since we are giving the drug together, before administering, we need to monitor the patient for precautions, assess for any signs of any contraindications. If there are signs of bleeding or any disorder that works closely in bleeding, patient must not receive the thrombolic agents. Now, we need to assess the baseline status before beginning therapy, like assessing the body temperature, the skin color, the presence of lesion, the apical pulse, the blood pressure, respiration, or the presence of sounds. Now, mark the chart of any patient receiving these precautions. Monitor patient response to the drug, and monitor for adverse effect. Check for the vital sign changes. Now, advise patient to not rub or touch the injection site or the IV line site to avoid complications. Now, we need to evaluate the patient regularly for any sign of blood loss, like the petechiae, the bleeding gums, bruises, dark-colored stools, dark-colored urines, or the brown coloration of the vomit, and the visual of bleeding. Now, in relation to patients should avoid activities that can cause injury resulting to bleeding. Monitor coagulation studies like the proton time, which is the common range of 10 to 13 seconds, the INR, which is 1 to 1.1 seconds or below, and the PTT, which is the 25 to 35 seconds. So we need to check for the normal value presented because when the patient is taking a thrombolytic agent, the time should be prolonged. It will indicate that the drug is working, and we need to evaluate for the therapeutic effects of heparin or the whole blood clotting time, and with a normal range of 70 to 121 seconds. And when patient receives heparin, it will be 2.5 to 3 times of the normal control value, or the activated partial thromboplastin time, which is 30 to 40 seconds, and it will be 1.5 to 3 times of the control value. And all of this is done to evaluate the effectiveness of the drug. We want to delay the blood clotting to prevent further clotting in the artery. So a longer time is recommended, or is what we want. So in starting drug therapy, be sure to arrange to type and cross-match blood, because in case we will need the blood transfusion, it won't be as complicated to find a compatible donor or to find a donor. Now, monitor the cardiac rhythm continuously if the drug is given for acute myocardial infarction, and have life support equipment to stand by as needed. Now, remember, a single mistake in all of these interventions can cost a patient's life. So it is important to know all of this, and that would be all. Thank you for listening.